in Western medicine, and we can go into the details of that if you're interested. Traditional beliefs and denials about the existence of the virus still persist today, and as the examples I told you about earlier on demonstrate that that is ongoing, and that's an ongoing challenge. It doesn't go away with a couple of brochures. It doesn't go away with a couple of cute little jingles on the radio. These beliefs are deeply held, deeply rooted, and they take time to engage and to modify. And then as well, burial practices that lead to contact with the virus, as my examples previously demonstrated, are ongoing. So this was the perfect storm. At the same time, across the ocean, there was similar demonstrations of profound ignorance being made in the American airways and elsewhere. Dr. Kent Brantley was one of the physicians who returned to the United States and actually had Ebola and required treatment. Now, Ann Coulter, I'm sure, does anybody know who Ann Coulter is? Put up your hands. Okay, somebody tell us, who is Ann Coulter?
Like an ultra-right-wing pundit.
An ultra-right-wing pundit, yes, that's a very generous description of Ann Coulter. She described Dr. Kent Brantley, who had contracted Ebola while treating patients in West Africa, as idiotic and as marinating himself in the medieval diseases of the Third World. So with that kind of a climate in West Africa and the frank ignorance that exists elsewhere in the world, this was a very, very difficult circumstance that in fact did create the perfect storm. I'm not going to go through the full length and the full history of the epidemic, but let me just highlight a couple of key points. This is a highly simplified timeline that I took from, or that I modified from various bits and pieces of information on the CDC website, where they provided a chronology, and a highly accurate chronology, which I would urge you to take a look at if you want to do more serious work on this. The Ebola virus, of course, as we know, was first identified in the 1970s in Zaire, or then Zaire, now the Democratic Republic of Congo. There have been about 32 outbreaks in the DRC, Democratic Republic of Congo, since, most of which have been relatively easy to contain, and easier as time has gone on and as experience has grown with containment and treatment interventions, most of which were, in fact all of which early on and then subsequent to later partnerships were pioneered by Médecins Sans Frontières, our Doctors Without Borders. In December of 2013, it's now fairly well recognized that patient 0 was a 2-year-old boy in Guinea. In March of 2014, the Guinea health officials did confirm Ebola, and WHO published its first report. Liberia also confirmed positive cases, and by May, we now were seeing cases in Sierra Leone, and then by June, the only organization, international organization, that was responding practically and materially with concrete medical care, logistical support, and so on, was Médecins Sans Frontières. MSF reported outbreaks and reported that the outbreak overall in the region was out of control and called for resources. It wasn't until August, following yet another declaration by MSF in July that the epidemic was out of control, that a public health emergency of international concern was declared by the World Health Organization. And that was declared under what are called the International Health Regulations, or the authority of the International Health Regulations. By September, MSF was screaming red and raw that this is completely out of control. And finally, September 29, the United Nations Security Council approved a resolution authorizing the creation of UNMIR, which is a special UN body now based in Ghana, to coordinate the emergency response to the epidemic. And then, even with that, resources and response was very slow. The bureaucracy of the international system, not just the WHO, but the bureaucracy of the international system, of the aid system, of OCHA, which is the Office for the Coordination of Humanitarian Affairs. The interaction between agencies was extremely slow relative to the pace and scope and scale and the spread of the epidemic. So much so that it was, by October, the United States government authorized deployment of 3,000 troops. So too did the French government, and so too did the UK government. Those are really the key sort of points in terms of the trajectory of the epidemic. There are a whole range of other sub-issues around R&D, around ethical approvals, around treatment protocols, and so on, all of which are extremely important, but they are subcategories to this broad timeline. And so what we saw was, what we witnessed really, is a complete inadequacy, a woefully inadequate response from the World Health Organization. And the World Health Organization, under its own constitution, is responsible for directing and coordinating, for being the directing and coordinating authority on international health work. And it's empowered to take action as soon as human cases of Ebola emerge, and this is according to the international health regulations. But the WHO has significant structural constraints. In an internal memo that was leaked, an internal review that was leaked in October of last year, it was reported that nearly everyone involved inside WHO in the outbreak planning failed to see some fairly plain writing on the wall. A perfect storm was brewing, ready to burst open in full force. And that's a direct quote from that leaked internal memo. So when we look at the structural constraints of the World Health Organization, here are a couple of them, and these are really the main ones. Geneva is the central office of the World Health Organization, and there are 6 regional offices. But in fact, it operates in a manner that is so decentralized that there are effectively quasi-independent and 7 separate organizations. The lines of authority and accountability simply don't exist. They're really more nominal than they are actual. The WHO, for example, has no control over regional operations or staff hiring. It has no control over who is appointed as head of a regional office, for example. Those decisions are made on a political basis by regional nation states. And that political basis is usually defined in the most generous of terms as horse trading. People get to a job of that kind because of their political connections, because of political payoffs, and not necessarily because of their actual competence in running a particular organization. The other key issue is that the WHO Regional African Office actually hampered the response, and it failed to facilitate entry of Ebola experts, for example. That's as an example of their failure to respond. It failed to facilitate entry of Ebola experts to Guinea. And what one sees when one looks at the structure of the WHO and its regional offices, in fact, is a fragmented organizational structure where there are quasi-independent units. There's a lack of policy coherence, and therefore there's ineffective strategies and, even more importantly, abysmally ineffective tactics in terms of actual implementations. Now, the WHO's funding is also a major challenge. We hear this in great schools of public health like this all the time. There has been a global health revolution, and there has been a global health revolution in the last 15 years or so. We've seen the emergence of major new institutions, the Gates Foundation, the Global Fund for AIDS, TB, and Malaria, a whole series of public-private partnerships, a whole series of product development partnerships, many of which I'm deeply involved in. We've seen the emergence and the virtual hegemony of the Gates Foundation. The Gates Foundation's assets are somewhere around $68 billion. They are required by American law, 501c3 law, to spend 5% of that per year. So what's 5% of $63 billion? It's $3.15 billion. And it spends more than its minimum requirement per year. And it spends its money on an agenda that it determines. It spends its money on an agenda that it decides is the appropriate agenda. It was very hard to be critical of the Gates Foundation, and I'm not being critical of the foundation as a whole or any of its particular choices. But what I'm doing is I'm trying to show just how disproportionate the resources and power relations are between a publicly mandated and ostensibly funded institution responsible for the global public health and a private family foundation that is able to determine, by virtue of the sheer volume of its resources, is able to determine the lion's share of the global health agenda. So in that global health revolution over the last 15 to 20 years, we've seen a massive increase in the number of institutions, whether it's Gates, whether it's the Global Fund for HTB and Malaria, whether it's product partnerships like DNDi, and others. And at the same time, we've seen a shrinking of the World Health Organization. The WHO is grossly underfunded, with little control over its own budget. In 2012, its budget was down 12% from 2011, and it was cut to $3.99 billion, roughly the same budget as the Gates Foundation. It had asked for approximately $5 billion to fulfill what it considered at that time a minimum set of operational requirements for its activities globally. Its budget was cut or maintained at $3.99